A good day and welcome to another AMA Insight Network conversation on AI and healthcare. I'm David Fawley, Director of Market Intelligence at the American Medical Association. Today, I'm excited to welcome Dr. Brett Oliver, Chief Medical Information Officer at Baptist Health in Kentucky. Welcome, Dr. Oliver.
Hi, David. Nice to be here.
Great to have you here. I, along with everyone here, really appreciate your taking a few minutes for the conversation, especially considering the number of COVID cases and hospitalizations are at all-time highs now. So before we jump into our conversation on AI, why don't you offer a little background on yourself and Baptist Health?
So as you mentioned, David, I'm the Chief Medical Information Officer for Baptist Health. I am a family physician by training and practiced for 25 plus years until just recently when I went full-time administration. We are a 9-hospital system across the state of Kentucky. We have 2,200 plus beds. We have about a 1,500 provider employed medical group. We deliver 1 in 3 babies in the state of Kentucky, and we have about $3.5 billion of revenue a year, just to give folks an idea of size and scope of our organization. We have a facility in Southern Indiana and we have a practice in Southern Illinois, but the majority of our business is in Kentucky. There's the obligatory slide of where we cover. And so that's just a brief background on Baptist. We have an ACO of about 55,000 lives and most forms of an integrated health network.
Great. Thanks for that background on yourself and Baptist. So I guess one of the big questions is, has AI arrived?
Yeah, I appreciate the opportunity to comment on that because I define AI as the ability of a machine to perform a task that mimics human behavior. And as far as that goes, while we are utilizing AI, while there are some incredible uses right now, I think the whole concept of it transforming care in present state is we probably ought to pump the brakes just a little bit on that. There's still a lot of things to work out and understand. There are quality questions. There are questions about when changes happen to an algorithm, how does that happen in a system? How is it communicated? There are questions about, does a patient need to know that AI has been used in their treatment plan and their care? Does a provider need to know? Some of these things can go on in the background and folks don't have to necessarily be aware. And then I think, at least in my experience, there's been limited reporting on the data sets used in these algorithms to understand if it's applicable, to the population it's being applied to. So there's tremendous potential. There's tremendous use cases right now, especially with some of the massive amounts of data that we're seeing, being essentially inundated with, whether it be through interoperability or patient wearables or RPM devices, things like that. But I do think a little caution, a little pump in the brakes. We're not quite there yet for the transformative effects that may well come with AI.
Fair point. Where would you say you are at Baptist Health in its AI journey? A few weeks back, we had the pleasure of speaking with some systems, East Coast, West Coast. It's good to be back in the kind of the Midwest here, getting some perspectives as well. And what's always eye-opening is everyone's at a varying stage or of their journey, and it would just be interesting to hear from yourself how Baptist has been, employing AI, if yet.
Yeah, we certainly have deployed AI in a number of different places, and I can certainly list several of those right now. But I think we're still relatively early in our journey, understanding how it can be best utilized. And I'm going to speak primarily to the clinical aspect of things. I think we also understand that we've got to get more engaged in it, both from clinical applications as well as the data that's used to drive these algorithms. It's one of those things that just a couple of years ago, as I started digging into some of these things, realizing that the data sets that are utilized in a lot of AI algorithms come from very small places, Silicon Valley, the East Coast. And so to your point of experiencing what flyover country perhaps it looks like, it's really important to us that those patients are represented in the data sets. But we've got several things at play currently. We utilize, probably one of the neatest things I think we utilize is we have both Viz AI and Rapid AI that takes perfusion imaging from our CT scanners, applies AI to it, and gives enhanced images to our clinicians via their mobile device for stroke patients, potential stroke patients, particularly with those with what we would call LVOs, or large vessel occlusions, that are amenable to procedures. Go in there and remove that clot, the patient's stroke is alleviated. So we've been utilizing that for a couple of years now. We have two at play, as we've been trying to figure out that we were relatively early entries in that market, trying to figure out which one that we want to go with. And so that's been kind of a fun way to vet things. It wasn't cost prohibitive in that regard. But that's looking at quality and efficiency. And we have a spoke and hub model for our tele-stroke services to our smaller facilities, and it's been really helpful there to basically provide that kind of care to the smaller communities. And then, with stroke, it's like a heart attack. Time is tissue, and so the faster we can get that information to the clinicians that can intervene, the better. We utilize Dragon Ambient Experience DAX, Nuance's product, using AI to convert an office visit or securely recorded visit into a structured note. Really excited about that. We've just finished a relatively small pilot, and we're going to expand that this fall and winter to more providers to improve burnout, efficiency. That particular AI is going to be different for each provider. Some are super efficient, but at the end of the day, they're just cognitively burned out, can't finish things, do it later on. Some really struggle getting their notes completed, and so there's different use cases for that. But most importantly, it's getting the clinician away from the computer and engaged again with the patient. That's the main goal with that. So patient satisfaction has been big, decreasing burnout, improving documentation. Some of the things that patients say that we maybe forget to document, it's been very helpful in that regard. In terms of COVID, because we are unfortunately in Kentucky a hotbed of surge right now, we had several things that we utilized AI with. We used some chat bots to improve essentially access to information, particularly early on when things were changing with quarantining and CDC recommendations for this or that, particularly prior to vaccination. And so that was a really important way. We couldn't answer all the phone calls. And so to be able to have patients have access to that kind of information in that regard was really helpful. We developed a COVID tool. We're an Epic shop, and we developed a COVID tool within Epic that was an algorithm to help identify high-risk patients to COVID. And that may seem really simple, but the practical application to that was when we were switching to video visits and telemedicine services, it was helpful to identify those patients that were at really high risk that maybe you didn't appreciate. So we continued their care through telemedicine versus those that had lower risk scores, and we're like, that's probably all right for you to come on in the office given the potential for complications with you. And then probably one of the really exciting things was using some remote patient monitoring and AI to keep our COVID patients at home, as well as get them out of the hospital sooner. When COVID first hit last year, patients would deteriorate very rapidly, and it was really helpful in feeling more comfortable getting them out of the hospital. So you're going to go home with this continuous monitoring device that used AI to alert us to deterioration sooner. Now, I didn't have a control arm for that, but I can tell you we've sent home 340 some odd patients with that device, and we've had none of them readmitted. So that's really exciting. I'll stop there. We've got a couple other initiatives on there, but that's plenty.
Well, and in some ways, I was going to ask you about how you evaluate and vet some of these AI before you implement it into your system, but it seems like what you were just talking about in terms of being able to test and learn during COVID times has been valuable, I'm sure. But are there any other kind of steps or processes that you've maybe started putting in place when you evaluate tools?
Yeah, for sure. The first thing, and this may seem self-evident, but it has to be a priority problem for us, obviously with COVID, and I outlined that issue. But there are a lot of bright and shiny things out there in the AI world that are really cool. For us, kind of the first level of screening, is it a priority problem for us? For instance, access. That's a really important thing for us at Baptist. Provider burnout, things. Does it address those things? And then I think what has evolved over the last couple of years is understanding where the original data algorithm gets its information from, because that's a change culturally with my colleagues as providers to understand what we're basing clinical decisions on. Maybe not gone are the days, but limited are the days now of the double-blind placebo-controlled studies to come up with the answer. that generally takes 17 to 18 years from workbench to practice, and things are moving much more rapidly, and I think for good. But so we need to understand the details of that original data algorithm. Does it reflect our population? And can we explain how it reached that conclusion? It doesn't mean always that that's going to be possible, and we can talk about that later, but in terms of the black box of AI. And then if the first two things, it's a priority and we understand where it's coming from and think it's applicable, then what we've really decided to do is we run those things in the background where it's not seen by patients and providers, but they're utilizing the Baptist Health patient data and circumstances and scenarios to see how does it do, and then comparing it to present state, whether it's another algorithm that we're comparing it to, or just current care without the algorithm. Some of the questions that come up and ethical things are like, how long do you run it? What kind of benefit do you need to see or not benefit before you say, okay, it's good to go or it's not? And that's where we've got some business intelligence folks that we have on staff that really help drive some of those numbers there. But those are probably the big things that we've learned and helped and changed our orientation process and how we evaluate things.
Great. And you've given some interesting examples of how you've integrated AI with some of your teams. What have you learned in these early kind of first couple of years that you've been deploying? I mean, obviously, it's not all sunshine and rainbows. There are challenges that arise. I guess any advice you would pass along to others that are in this early part, I guess, of their journeys of considering AI applications? Like, are there any challenges where you're like, why didn't we catch this earlier?
I think understanding where your culture is as an organization or as a practice. When I first started as CMIO, there was this continuum of folks that didn't even understand how the patient got their email, which wasn't an email, it was their in basket within Epic. But how in the world could a patient send me a message? And struggling over here to those folks that wanted the most advanced AIs to drive their clinical care. So trying to gradually move that culture along. And the way that I've approached that is, having physician champions, physician leaders that can understand the projects that you have in play and the concepts and how you're trying to drive things and why. I think that's a big thing, is the clinicians just want to understand why. But part of that buy-in is a struggle, I think, with AI in general, is this black box issue where you're a company, you've developed some AI, say it generically, that AI could be proprietary. That could be your secret sauce. If I say, well, how do you get to that? What's the algorithm made from? If they open that black box up, that may be what their whole business model is based on. So they may not be able to do that. So how do we, as an industry, as an organization, as individual providers, come to a point where we can trust that? What regulations, oversight need to be in play? I'm a small government guy, but at some point, if I can't look into that box, somebody that we can trust at some level needs to be able to look into that box that has no interest, so we can make sure when I talk to a clinician, I say, when it gives you this advice, 98% of the time it's going to be a large vessel occlusion that you need to go in and retrieve. So that's a challenge. And I don't know that I've got the answer there. I know the FDA's got some answers there, and working on that. But I think that's where companies could really advocate for some kind of process that allows an organization like ours to say, oh, okay, we understand that makes sense. Sometimes AI won't make sense. It'll pull in, different data that's why, it could have advantages to the way we think. So I think that black box issue is important, because ultimately the liability lies with the clinician who's delivering the care, and we need to understand where that is coming from. I think also then with the algorithms and AI, who maintains them? And if changes are made, how is that articulated to the end user, to the system, to the patient? So there's still lots to be worked out. You see a lot with bias in the models. Where do these the models aren't biased themselves? It's the data that comes in, and so how do we overcome that? How do we make sure that the right populations are represented? And you start seeing that amalgamation of data, and I think that will really help some of those questions.
No, all great points. And in some ways, you kind of answered another question I had here about what concerns you and your peers have about these new technologies and how companies should address them. But I think it's that, there's the black box that we're dealing with here, and that's kind of the proprietary secret sauce of these companies providing these algorithms. And how do you get past this uncertainty, which, clinicians want to understand, well, wait, how are you getting to this point? So
Right. And
excellent point.
if I can't give them the answer, if it's a black box, and again, I appreciate that from a business standpoint, then I at least have, that's why we run it in the background. I at least have to go, okay, here's how you've been treating sepsis. Here's our mortality rate from sepsis. We've been running this in the background. And if it had been identified when this fired, here's this, here's what we think could have happened to our percentage of mortality percentage. So, this against basically saying this is your data because we've run it on our system with our patients. That's been the most effective way that I found to convince folks, although it's still of a concern. As well as one thing I would add too, that's a challenge is just the data itself and how it's presented. If it's just a remote patient monitoring that dumps a bunch of heart rate data on a provider, that's not helpful. In fact, I would argue that can be harmful. It's noise. You can't review it all. Have to be really, really careful that whatever data is presented, it's actionable. It's not just an FYI. We have, as clinicians, we have way too many FYIs that I think everyone that sends it to us thinks that's a good thing. But when you conglomerate all of that, it is tough. So yeah, make sure that whatever is presented to the clinician is actionable, which I think is the whole point of a lot of AI, is taking these mass amounts of data. But I've seen some where it doesn't seem to do that. So
Yeah, I can only fathom from a physician's perspective. So you've got all your patients coming in. Do you want my Fitbit or Apple Watch data? And they're like, oh, wait, hold on.
yeah, no, it's funny. We did that. When we first went live with Epic several years ago, we integrated Fitbit data, and I hope none of my team members will listen to this, but it was one of those things that was celebrated, and it was, wow, isn't this cool? And it's useless, clinically useless. It's just amazing some of the things that sound really good on this side that once you get at the bedside with a patient or in the exam room, it's just like, oh my gosh, what am I supposed to do with 100 different heart rates from last night?
So thinking about health systems that are implementing AI solutions, can they feel confident without data scientists that are employed by the hospital? Like, how critical is it for you to have that labor in place just to feel comfortable with the algorithms that you're deploying or other AI solutions?
Yeah, no, it's a great question, because obviously we do not employ a true data scientist at Baptist Health, so it can be done without that. But now we do have decision support folks, as kind of how we call them, business intelligence, that looks at data outside of reports that can be run out of our EHR. And so their role is super important when to help tease out the math and some of the algorithms that we have. But it's not, I don't think it's critical to have a data scientist per se. I would love to have a data scientist. I think it's great. And I think of a data scientist as someone who is going in and looking, not with any specific outcome in mind, but looking for those relationships and just having a little bit more free licensure. Our team is mostly, yes, bring them the algorithm, show them some of the math and see that it works with them, or it correlates with some of the data that we generate ourselves.
Fascinating. Good to hear. I guess one last question, kind of the Hail Mary. If you were starting from scratch right now, today, and knowing what you know so far, what would you do differently? Or what would you recommend to somebody who's just right at the start saying, hey, I hear AI could really help make a difference in how we care for our patients, as well as improve burdens on our clinicians and physicians?
At least for an organization of our size, so kind of a moderate health system, two things. Governance is so important, and it's just kind of dry and boring. I get that, but if you could have strong governance up front, so you have a standardized intake process, evaluation process, review process after how often are you going to go back and look at these things and check the data? What are your KPIs? But to have that strong, so it's not popping up here and there in random ways. You've got two different algorithms that are looking at the same thing. So that strong centralized governance, I think, would be really important. And then educating your staff, your providers, your culture at every opportunity you can. Finding that group of maybe early adopters that can also help you with that, because it is a cultural shift that can be challenging at times. That the silver lining to the pandemic, you've heard it with telemedicine. I think the same thing can be said of AIs. It's really allowed people the time to say, hey, wait a minute, this worked okay. This was good. I can deal with this. So I think governance and in a continual educational process, nothing necessarily formal where you have chapters of a book to read or something like that, but just the ongoing, hey, don't assume that your colleagues know about any of this. Continue to throw things up against the wall for them, see what sticks, see what could be helpful to them clinically, and then go back to that strong centralized governance.
Wonderful. So, Dr. Allworth, thank you again so much for joining us. It was great to hear from you and the insights. Obviously, we're all very early on, and these important lessons are helpful for everyone in our network. And all the best this fall. Let's hope we're turning the corner and better
Yes,
days
sir.
are ahead.
Yes, sir. Thanks, David.
Thanks a lot.